We'll go on to our next speaker, which, interestingly enough, happens to be me. And therefore, I have to introduce myself again. Once again, I am David Suskind, one of the pediatric gastroenterologists here at Children. And really, my passion is nutrition, and I have strong belief that diet can not only improve the outcomes for individuals who have inflammatory bowel disease, but also other chronic illnesses that we're seeing in the world today. What we need to do, and what we're doing here at Seattle Children's, and what Dr. Damon's doing at the University of Washington, is push our knowledge forward in this area. And so today we're going to talk, or I'm going to talk about fecal microbial transplant. We've heard about the microbiome and how important it is in inflammatory bowel disease. But now the question is, can we change it? And if we can change it, how? Obviously, this conference is on diet, so we're going to be focusing on how diet can change the microbiome and improve patients clinically, as well as the inflammatory burden that they're experiencing. And just like Dr. Damon, I am going to tell you what I'm going to talk about, although I was not clever enough to think about repeating it at the end. Next talk. And so we're going to talk about inflammatory bowel disease, and also, Dr. Damon has already focused on this area, but I just want to briefly touch base on it again. We'll talk about the fecal microbiome, the immune homeostasis, and this is really an important part, especially when we talk about some of the foods that are in our diet today. We're going to talk again briefly on what determines the fecal microbiome, and then we're going to focus in on how diet can modulate the fecal microbiome, as well as our clinical and research experience with diet in inflammatory bowel disease. So this is the IBD paradigm, and you've already seen a version of this. I'm very simple individual, so I only have two circles that are intercombined. And the immune dysregulation is really telling us that it's the immune system that for one reason or another has become awry and is starting to attack the bowels. And we know that the immune response is a very important component of that. And we know that our genes play a very important role in that immune response. And we feel that the microbiome is the other half of that. The immune system is upregulated or attacking the bowels, likely secondary to the bacteria, the microbiome that we each have. And we know that environment plays a role. We know that antibiotic plays a role. And again, if you can find that paper by Crohn on antibiotics and IBD, it's a phenomenal paper. And we know that the food that we eat plays a role in our microbiome. But the real question is, which of these two plays the bigger role? Is it the immune response and our genes that lead to that immune response, or is it the microbiome? And I'm going to try to convince you today that it is truly the microbiome that we really need to focus in on. And if we look at the historic data we have, the fact that the incidence of inflammatory bowel disease continues to rise over the last number of decades. Again, that points more to the microbiome. If this were primarily a genetic disorder that really affects our immune system, and that was it, if it were such as cystic fibrosis or Alagille syndrome, then we would expect the incidence of inflammatory bowel disease to be rather static, to not change significantly over time. But we see since the 1930s and 40s this significant rise in the number of individuals with inflammatory bowel disease. And although we haven't done a study here at Seattle Children's, I actually feel that we see much more inflammatory bowel disease now than I even saw 10 years ago. So again, the incidence points to this being an environmental disorder and the fact that the microbiome may be the bigger pool. But also the prevalence. If we look at where we see inflammatory bowel disease, you'll note that it's primarily in Western or industrialized countries. And you can see there is a big variation between those of the industrialized nations and those of the non-industrialized nations. But what I think is even more fascinating than that is that if you were born in a non-industrialized nation, let's take India, for example, then your incidence or your likelihood of developing IBD would be very similar to those individuals around you. Let's say then you moved as an adult to a westernized country, let's say the UK, and then your incidence would actually still be more similar to those individuals who were in India. But what the kicker is that your offspring, your children, likelihood of developing IBD would actually be similar to the individuals in the industrialized nation in the UK versus that of the individuals in India. Again, pointing to environment and therefore pointing to the microbiome as being a major player. And we've talked about the fecal microbiome, but I'm going to kind of reiterate some of the things that Dr. Damon said, that the microbiome is this wonderful, vast, little organ that resides within us. It's doing things for us, and we want it there. But each of our microbiome varies, and it varies significantly from individual to individual. What the microbiota is in each of us is plastic, meaning that it changes. It changes depending on what we do, and it's personalized. It's meant for me. And what are those bacteria doing? Well, they're adapting. They're adapting to us, their environment. I love this picture. This picture is a phenomenal picture because it's a picture of the microbiota. And what it shows us is that the microbiota is diverse. You can see that there are different types of bacteria, and they're all together. They're actually interacting. They're talking to each other through chemical signals. But they're not only talking to each other, they're actually talking to us too. They're talking to their host. And we want them there. We need them. As Dr. Damon pointed out, they do important roles for us. They break down food for us to give us increased calories. They make vitamins. They protect us. But we want to keep them a little bit away. We want to keep them within the lumen of the GI tract. We don't want them to obviously invade the rest of our body. And our immune system has set up some ingenious ways of doing this. And I want to focus in on a number of them. One is this outer mucus layer. And this outer mucus layer is so important. Again, it keeps the bacteria from getting to the epithelial cells, getting to the lining, and triggering an immune response. The other important components are antimicrobial proteins that the epithelial cells make, but also tight junctions. These are proteins that keep the epithelial cells closely together so the bacteria can't get down and stimulate the immune system. And then we have cells. We have intestinal macrophages, dendritic cells, B cells, T cells, which elicit an immune response if they feel there's an inflammatory or an infectious process going on. And these concepts are really important. And I want you to remember these concepts because we're going to be talking about a number of studies specifically on diet and how they affect these areas of the immune system. So what shapes our microbiota? And again, Dr. Damon has done a phenomenal job in going over this already, but I'm going to focus in on two areas. I'm going to focus in on our genes, versus nutrition. Again, because I think a lot of times we've really looked at inflammatory bowel disease as a genetic disorder and not necessarily an environmental disorder. The genes, if they were to affect the microbiome in a significant way, then you could argue, yes, IBD is primarily a genetic disorder. But if it's the nutrition, then really that points more to an environmental. And happily enough, a fellow named Commodi did a phenomenal study to help answer this question. So he took 5 different inbred species of mice, and they gave them different diets. But these were not just any ordinary mice. These were inbred species of mice that were deficient for genes relevant to the host microbial interaction. These were MyD88 knockout, NOD2 knockout, and NOD2, as we all know, is the most common genetic mutation in Crohn's disease. The OB mouse, the RAG1 knockout mice, and a species of mouse that had been outbred greater than 200 times. And they fed them either a high-fat, high-sugar diet versus a low-fat, high-fiber diet, or a mixture of the two diets. And what they found was that diet shaped the gut microbiota similarly across all the different mice species, which really points to diet being the primary mover and shaker of the fecal microbiome as opposed to our genes. What they also found was that the changes that they saw were reversible. So if you had been on a high-fat, high-sugar diet and you went to a low-fat, high-fiber diet, that your microbiota shifted within them. But I think another very interesting thing that they found in this study was the microbiota seemed to have a memory. So the abundance of different species on the high-fat, high-sugar diet really depended on the number of prior shifts. So what you did in the past really affects what happens in the future in terms of the microbiota. But that's in mice. What about in humans? Because obviously we would love to cure IBD in mice, but really our focus is making sure that we humans do well too. And this is a study by David et al. And he looked again at diet in healthy individuals. And he looked at individuals who went onto either a plant-based diet or an animal-based diet. And as you can see, the plant-based diet had a high degree of fiber, while the animal-based diet had a high degree of protein and fats. And then he looked at something called alpha diversity and beta diversity. And alpha diversity is the relative diversity within a sample size, or a sample of stool in terms of the microbiota. And it didn't really matter which diet you were on, at least in this study. The overall diversity in each sample was similar. It didn't mean that the same bacteria were there, it just means that the diversity was there. And then he looked at something called beta diversity. And what he found was that in each the animal and the plant focused diets, the diversity as compared to the baseline diversity or the different organisms in the sample significantly shifted. What he found was that the animal-based diet actually shifted the microbiota much more significantly than the plant-based diet, but there was a shift in both. But what he also found, as we would expect, is that it didn't only shift the bacteria, but it really shifted what the bacteria were doing. And so it may not only be important to look at the microbiota in terms of who is there, but really what they're doing on a minute-to-minute basis or day-by-day basis. And what you can see here is that the green is representative of the plant-based and the red is representative of the animal-based, that the plant-based diet increased the small chain fatty acids, and the metabolism or the mechanism to produce those small chain fatty acids, much more significantly than that of the animal-based diet. And that shows a shift in their function, and this shift is important because we all know that small chain fatty acids are the primary nutrient or a significant nutrient for colon and intestinal health. In the animal groups or fed individuals, there was an upregulation of the putrefaction or the fermentation process within the bowels. And again, pointing to the importance of not only who's there, but what they're doing. So then we ask ourselves, is there any evidence that we see shifts or changes in diets that we use in inflammatory bowel disease? And happily enough, there is a study. It's a small study, not many individuals, 4 that actually, I believe, completed this study. But this study by Walters was a crossover study, meaning that these individuals who had actually Crohn's, but their Crohn's was actually quiescent, these individuals went on to either the low residual diet, which is a diet that we usually recommend if somebody is flaring, as opposed to the specific carbohydrate diet, the diet that we're going to be talking a lot more about in the upcoming talks. And what he found was there was a significant shift depending on the diet you were on. The low residual diet, the number of bacteria or the diversity didn't actually shift that much from the baseline diversity for the individuals who were on it, as opposed to the specific carbohydrate diet where there was a significant increase in the number of species seen, 134. What was also very interesting in this study is that after each of the diets, there was a washout period. And while the low residual diet, their washout period, individuals kind of resumed their baseline microbiota, in the SCD group, the individuals actually seemed to continue to have that shift in the microbiota, again, pointing to maybe a memory that our microbiota may have. So we know that diet can change our microbiota. We see that in animals and in human studies. What is the evidence to suggest that diet is a causative agent, or at least one of the causative agents in inflammatory bowel disease? There are a number of nutrition studies, and I'll throw this out here to begin with. Nutrition studies are extremely difficult to do. Think of trying to look at a large population of people and then trying to figure out exactly what they're eating. So you have to take all nutrition studies with that bit of advice, because it is quite difficult to do nutrition studies. But a number of studies have linked diet, the development, or changes in the diet with the development of IBD. And what they pointed out was that a high total fat, omega-6 fatty acid, and animal protein diet seemed to increase the risk of Crohn's disease and ulcerative colitis, while a diet high in fruit and fiber intake decreased the risk of Crohn's disease, and a diet high in vegetables seemed to decrease the risk of inflammatory bowel disease, or ulcerative colitis. But where we maybe get the best evidence that diet plays a role in IBD is really from animal studies and some human studies that we're going to be talking about. Western diet was noted to induce dysbiosis with an increase in E. coli in CBAC-10 mice. And CBAC-10 mice are mice that are predisposed to developing inflammatory bowel disease. And what we see here in this Western diet, and that's defined as a high-fat, high-sugar diet for mice, is that we see a number of changes in these mice. If you look at this picture right here, that is showing something called Claudin 2. And Claudin-2 are pore-forming proteins, and they induce kind of a leaky gut within the mouse. And you can see individuals fed conventional feed, there's not a lot of that Claudin-2 present, but in the high-fat, high-sugar, you see this presence of Claudin-2 significantly increased. The other thing that a high-fat, high-sugar diet does is decrease your mRNA levels of MUC2. And what MUC2 is the leads to the development of the mucin, or that mucus layer that protects the GI tract. And when you actually stain for that mucus layer that protects the GI tract, again, the conventional diet has a large number of mucus, keeping that bacteria away, as opposed to the high-fat, high-sugar diet, where that mucus layer is significantly decreased in amount. So is it just a high-fat, high-sugar diet? It's hard to know, but there are components within our diet that have been shown to actually induce inflammation as well in animals that are predisposed to developing inflammatory bowel disease. So we're going to focus specifically on the emulsifiers because there's much more evidence in this area. But there are other additives that are put into food that probably still deserve further research as well. So maltodextrin is one of those emulsifiers, and maltodextrin really wasn't a part of our diets until after the 1940s, and it has increased in our diets significantly over the last number of decades. Currently, probably about 60% of all packaged foods have maltodextrin in it. It's generally recognized as safe by the FDA, and that's a labeling that the FDA gives food additives depending on a certain number of processes that they have to prove to the FDA. And it is a chemically, enzymatically processed starch. And so what do we see in animal models of maltodextrin? Well, we see that maltodextrin increases as opposed to glucose, it increases the biofilm formation. And what biofilm is a bacterial layer. And this has been noted to occur in Crohn's disease, and again, in animal models as well, when animals are fed maltodextrin. It also increases the adherence of bacteria onto the epithelial layer. But what I thought was also fascinating is that mucus layer, that layer that protects the epithelial cells from developing an immune reaction, is compromised with maltodextrin. Here you can see the mucus layer is dark black, and this is controls, so they're given regular feed. And here, individuals are given maltodextrin, and you can see that the bacteria, as represented by pink dots, are coming quite close to the epithelial lining. Again, coming close and able to elicit an immune response. So is it high-fat diet, high-sugar diet, and maltodextrin? Well, no, there are actually a number of other emulsifiers out on the market too, and it doesn't seem to be only the maltodextrin. This is a phenomenal paper out of Nature looking at two, again, very common emulsifiers, one called CMC, the other is P80. And if you look at your food items, you're not going to see CMC or P80, you're going to see something like modified cornstarch or an emulsifier listed. And what you see again with the additives in this animal model that is predisposed to developing inflammatory bowel disease is you see that mucus layer in the CMC group significantly diminished as opposed to if they're fed water. So those bacteria again get closer to that epithelial lining, able to induce an immune response. And what you also see here is increased permeability. And what they did was they gave dextran, they gavaged it into the animals and then measured it in the blood to see how leaky or how permeable the lining of the GI tract was. And they saw that when you fed the CMC or the P80 in these animal models, that the permeability increased significantly. And what I also think is extremely important to realize is in these animal models, which again are predisposed to developing inflammatory bowel disease, interleukin-10 knockout mice, that the incidence of colitis is significantly higher as opposed to when they're just fed water. So again, pointing to not only diet, but probably diet additives as being part of the issue in IBD. So this begs the question, can we flip the paradigm? Can we change our thoughts from IBD being really an immune disorder to a disorder of the microbiome where the immune system is upregulated because of changes in the microbiome? And can we change the microbiome from being kind of an angry, not happy microbiome or a dysbiotic microbiome to a happy microbiome? And by changing it, can we actually improve the overall outcomes of our patients? So the interesting thing about IBD and about medicine is that we've actually known for a very long time that diet has a tremendous impact in patient outcomes. And we know this through exclusive enteral nutrition. And this is something that we do here at Children's a lot. It's the mainstay of nutritional therapy in Crohn's disease. And what it is when we give exclusively a formula to an individual, and it's for about 8 to 12 weeks, and we give them no other food or drink except for water. And we give it via drinking it or via a nasogastric tube, because some individuals get kind of burnt out by drinking the same thing on a day-to-day basis. But the amazing thing is we really know that it works. There have been many studies, but there have been a number of meta-analysis, and this meta-analysis looks or compares it to that of steroids, and it works equal to the steroids in terms of getting people into clinical remission. But there are a number of studies that I really want to focus in on, because there are a number of studies that really point, again, to diet being a very important component of treatment in IBD. This is a trial by Baroli, and it's a prospective open-label randomized controlled trial. And he used steroids versus a polymeric formula. So just a standard formula that you can get off the counter at your local grocery. And he looked at individuals clinically, and he measured the pediatric Crohn's disease activity index, which is a validated score for Crohn's disease. And he looked at laboratory studies. But most importantly, he looked at ileocolonoscopy at the beginning and at the end of the study. And what he found, and this is kind of a busy slide, so I'm going to focus on what he found. What he found was that the PCDAI, or that validated score for inflammatory bowel disease, improved dramatically for both groups, those on the formula and those that received steroids. And they both had moderate disease to begin with, and they both went into clinical remission, both groups. But what he also found was that the inflammatory markers, the SED rate, the CRP, the albumin, which is actually a negative acute phase reactant, those two normalized equally in both groups. And that was fantastic. So now we knew that nutrition worked just as well as steroids. But what was not the same was the histology seen on endoscopy and colonoscopy. When they looked at the histologic score, they saw that the formula group worked so much better than the steroids, that actually there was a statistical improvement in the amount of inflammation in the formula group as compared to the steroids. The steroids actually did not change significantly from the beginning to the end. And we know that about steroids. So steroids work. Steroids are great, and we use them, but they don't necessarily work as well as EEN. Another really important study by Kanani looked at whether or not it was just one type of formula, or if different types of formula being broken down more work better than the polymeric formulas. And this was compared to steroids, and they gave it for 8 weeks. And then they followed up with these individuals over a year's time. And they put them on mesalamine therapy as maintenance. And as we all know, mesalamine therapy are not necessarily the strongest medications we have for Crohn's disease. And what he found was that all of the groups worked equally well. The steroids worked just as well as the polymeric formula, which worked just as well as the semi-elemental formula, that worked just as well as the elemental formula. So all these groups worked equally as well. There was no significant difference between the two groups clinically. But again, pointing to the importance of nutrition in IBD, he looked at these individuals over a year's time. And what he found was that there was a significant difference in clinical relapse rates. For those individuals who had received EEN, there was a 30% relapse rate. For those people who received corticosteroids, a 70% relapse rate. And this might point to the fact that maybe steroids are not necessarily good for the microbiome or for IBD if it's used too much. Or it may point to the fact that changing the microbiome through diet, through EEN, gives your microbiome a memory that may actually lead to longer-term improvement. So we know that formula works. The next question is, can we do a hybrid of that? Are there studies to suggest that diet might work too? And this is a study by Ari Levine's group coming out of Israel. And he looked at 47 individuals. The nice part about this study is it's partially peds and it's partially adults. And he looked at these individuals and said, okay, you're going to go on to formula, but you're also going to have a diet, an exclusionary diet that you can eat certain types of foods. And what he found was that when they did go on to the formula and the diet, that there were 40 individuals here, 27 of them got into remission. 3 individuals responded, but 10 individuals actually didn't respond at all or failed the therapy. But there was a portion of the individuals in this study who said, you know, really, the formula, it's kind of nasty tasting. I don't really want to drink it. And I want to just do the diet alone. And so there were 7 individuals, 4 peds, 3 adults, who just went onto the diet and the diet alone. 6 of those individuals were able to get into remission, and 1 individual responded. And so, again, pointing to the fact that diet does have a place in IBD. And he looked at the clinical outcomes. He looked at the Harvey-Bradshaw and for the adults, as well as the PCDAI, the validated score for Crohn's. And again, both groups went into clinical remission. And again, both groups had improvement or normalization of their inflammatory markers. Again, pointing to the importance of diet. So that brings us to what we do here at Seattle Children's. A few years ago, I had a wonderful family come up to me and said, you know, our child has been on the specific carbohydrate diet and has done phenomenally well. And of course, being a skeptical physician, being very science-based, I said, well, he might be doing well, but really, what are his inflammatory markers? He might be feeling well, but if there's still inflammation going on, then it's not really working. So they were wonderful, and they said, okay, well, we'll check the inflammatory markers. And lo and behold, the inflammatory markers were normal. And this individual had been here for a very long time, so we had historical data on him showing that he really did have pretty significant Crohn's. And that individual has done well and has continued to do well, and actually spiked my interest in the SCD. And so from there, we developed our clinical program. The SCD, as many of you already know, removes all grains. It removes milk products except for yogurt that had been fermented greater than 24 hours. It removes sugars except for honey. And it was started by a pediatrician. That's the other reason I really like the SCD, because it was, again, a link. And this pediatrician was using it to treat celiac disease before we knew that celiac was just gluten. And he treated these individuals, and they did phenomenally well. And it was actually pretty popular. It was called the banana diet, and actually there are articles written about it back in the 1930s and 40s. But as any good physician does, it worked in one area, so he said, well, let me try it somewhere else. And so he saw the daughter of Elaine Gottschall, and who had ulcerative colitis, and treated her with the specific carbohydrate diet, and lo and behold, she did great. And Elaine Gottschall went on to write Breaking the Vicious Cycle, and as medicine slowly forgot about the specific carbohydrate diet, it continued on and was refined by Elaine Gottschall over the years. So now we had an individual who had done remarkably well, and we wanted to see if we could find other individuals that followed the same history as this young man. And we looked through our medical records, and we tried to find individuals who had done the diet, who had not done any medication at all, and used the diet as their sole treatment. And we were able to find actually 7 individuals. And 7 individuals, 5 male, 2 female, they ranged in age 7 to 16, and they had mild to severe disease based on histology. And they had been on the diet ranging from 5 to 30 months. And what we found was, based on the PCDAI, they had active symptoms and active disease. And lo and behold, after 3 months, they had all gone into clinical remission. And that truly excited me. And we could see that for those that we had follow-up on, they continued to do well. But what really excited me is what I saw in their laboratory results. Their CRP, their inflammatory markers which gauge inflammation in the body, were quite elevated and had all normalized by 3 months. Their albumin, which is, again, is a negative acute phase reactant, so goes down during inflammation, improved and normalized for the vast majority of them over time. Their hematocrits also improved. So this was not only showing that diet might improve somebody clinically in terms of symptoms, it was telling us that diet was affecting something within the body, likely the microbiome and the immune response, and decreasing the amount of inflammation seen. So, just like Sidney Haas, we wanted to do more. And we wanted to see if diet would work in a prospective study. And so we did a prospective study in Crohn's and ulcerative colitis. And these 8 individuals were aged actually 8 to 21. That's a mistype. And they had active disease, but they didn't have any change in their medication regime. And we put them onto the diet, and we followed them from baseline to 2 weeks, 4, 8, and 12 weeks. And we looked to see how they did. We looked at their clinical and laboratory responses, as well as their microbiome. And we actually did this study in conjunction with an individual group down in Atlanta, Stan Cohen's group. And what you'll see is the first 9 individuals are from Seattle Children's. The last 3 are from the Atlanta group. And that's going to be important just because some of our laboratory values were different, and you'll see that in the upcoming slides. But what you see here is that the vast majority, again, this is the PUCI and PCAI, that the vast majority coming in with active disease went into clinical remission. And the individuals who had stars were individuals that were not able to maintain the diet. And I think that's a very important topic. And we're going to talk more about that when we talk about the practical aspects of the diet. And then 2 individuals actually didn't respond to the diet and may have actually worsened on the diet. So I think that's another really important part to remember, is that no treatment is not without its issues. And so when we talk about the practicalities of the SCD, we're going to look at that issue as well. But the vast majority of individuals did quite well. And when we look at their inflammatory markers, their C-reactive protein, you'll again see for those individuals who were able to maintain the diet and those individuals who responded to the diet, their inflammatory markers improved. Now, this slide, you don't get the significant impact or visual impact from our labs because we're put next to the different reference range of Atlanta, but you can definitely see that there was significant elevation in the CRP in the Seattle group as well as the Atlanta group, and both groups had normalization in those people who responded to the diet. And we wanted to make sure that the inflammation that we could detect through Calprotectin, a stool study measuring inflammation specific to the GI tract, was also improving. And once again, for those people who responded to the diet and for those people who were able to maintain the diet, their calprotectins normalized or came down, except for 2 individuals. This individual who had Crohn's disease actually was clinically doing phenomenal on the diet, and we were fairly surprised about this calprotectin. So we repeated the calprotectin after a month after the study, and it actually had normalized at that point. So we're not really sure why that test is the way it is. The other individual normalized, but then had a little bump up here, and we actually found out that she was then had broken the diet about a week and a half before the end of the study. But again, points to the fact that diet has a clinical impact. And these are the 2 individuals who didn't respond, and as you can see, their calprotectin actually seemed to increase on the diet. So we see that it works in terms of clinical, we see that it works in terms of laboratory response, but the question again is, what is that mechanism of action? And we feel that it is the microbiome. And this is a sample of one of the individuals. We've actually analyzed the vast majority of individuals, and they all seem to share what we would consider a dysbiotic trend. So they all had different shifts in their microbiota that we would consider dysbiotic. And in this individual, it was a significant increase in the amount of E. coli and a significant increase in the amount of ruminococcus. And this is their baseline percentage, so about 12% E. coli, 15% ruminococcus. And you can see after just 2 weeks on the diet, the numbers percentage-wise come down significantly. And by 12 weeks, it's only at 0.2% for the E. coli and 1.9 for the ruminococcus. And we're not the only ones. So there are a number of groups out there doing research in this area. This is a study from the Stanford group, and it's Jen Burgess' study. And she actually looked at really a small group, but looked at their inflammatory response or their lab response, and looked at both a liberalized SCD as well as a strict SCD. And as you can imagine, she noted a significant decrease in normalization for most of her children on the SCD. Oh, sorry, these are out of order. So this is another study. This is from Stan Cohen's group down in Atlanta, and he too found very similar findings that we've found up here. He had 9 children with active Crohn's disease. He had no changes in their medication, but he was able to follow these individuals over an entire year. And as we found, he found the PCDAI, the validated indices for disease activity, normalized. The inflammatory markers normalized for the vast majority of these individuals. But what he found, which was also absolutely fascinating, is he found that the mucosa seemed to improve as well. So he did capsule endoscopies on all these individuals, and he looked to see if there was any changes. And he found that on capsule, it appeared to improve. And there are other diets out there. So the specific carbohydrate diet is not the only diet that has been reported to improve patients with IBD. There's the GAPS and the Maker's diet, which are very actually similar to the SCD with slight variation. There's an IgG4 targeted exclusion diet, and actually there was a recent paper on this as well. And it seems to improve patients clinically, but it doesn't seem to shift the inflammatory response. And I think that's very important when we talk about dietary treatment in IBD. Same thing with the FODMAPs. It seems to improve symptoms, but not necessarily the inflammatory response. A very interesting study that unfortunately has not had a follow-up yet is a study by Chiba, where he looked at a lacto-ovo vegetarian diet in individuals with Crohn's who had just gone into remission, whether by surgery or by medication. And he saw that on a lacto-ovo vegetarian diet, there was a significant decrease in the relapse rates as opposed to individuals who went on to just a regular diet thereafter. So the march continues, and this is actually our current study. This is a study, and this actually has not been shared before, so you guys are getting to see it for the first time. This is a study that is a double-blind double-blind diet-controlled study. Now, it's double-blind, meaning that I don't know what they're eating, and supposedly the patient doesn't know what they're eating because we have a study chef making all the foods. But I'm guessing the patients figure it out pretty quick. And we divided the individuals who had active Crohn's disease into one of 3 groups, either the SCD, SCD with oats and rice, or a whole foods diet minus milk, wheat, corn, and processed foods. And we've now had 5 individuals that have enrolled. And unfortunately, I don't know what diet they're on, so I'm not going to be able to give any spoiler alerts here. But what we do see is that these individuals who, again, have active disease based on PCDAI have had significant improvement for all of them except for one. And again, we're going to touch base on that during the next talk. And again, we see significant improvement in the C-reactive protein in all groups, all individuals, except for the one person who has not clinically done well on the dietary change. Unfortunately, I do not know which diet she was on. And again, the stool calprotectins, for those that we have, significantly improved. And there are more studies. So, and this is actually one of the things that excites me tremendously, is that there are many other groups that are now starting to do research in diet in Crohn's disease, as well as diet in ulcerative colitis. So in conclusion, it's really important to realize that the fecal microbiome is complex, it's beautiful, it's biologically important in inflammatory bowel disease. It's important to realize that the fecal microbiome modulates us, so it is likely a causative agent in IBD. But what is also amazingly important to realize is that we can very easily modulate the fecal microbiome through diet and other means. Thank you very much. Yes?
There seems to be a contradiction between the enteral nutrition, exclusive enteral nutrition, and SCD.
Mm-hmm.
It doesn't matter what formula, and these are, sourced from milk and corn, syrup, solids.
And the most amazing thing is, it does the exact opposite in terms of the fecal microbiome. So the part of the dilemma is that we, as human beings, are not as smart as we wish we were. And so there isn't an absolute answer to why we see such profound improvements in EEN and improvements in SCD, and why the microbiome shifts dramatically in two different directions. Formula actually decreases the biodiversity, SCD increases the biodiversity. The types of bacteria and the metabolomics are different in each group. But what I would say is sometimes it's not necessarily just where you end up. It might be where you're leaving from. So it may be the fact that you're just changing, and wherever you are right now in terms of the microbiome is just the place that these individuals don't need to be in. And just by changing it significantly, you're seeing the response. But to be honest, we don't have a true answer to that question yet.
Are you also studying the microbiome of these patients with different diet types?
We are.
So the one who's not responding, have you looked at?
Unfortunately, the analysis and the tests are not cheap, so we batch them all, and so we won't have that answer until the end of the study. So, I have to. I see him almost every week, so I have to be nice.
So thanks, David. Not to be a heretic in this room, and discussing the microbiome. This idea of two remarkably different shifts in the microbiome with the same end result begs the question. Also, is it really the microbiome, or is it that third component, right? Which is the barrier function that you're modulating? Is it that you're taking out these food additives by going to a different diet, which doesn't have them, that helps restore that barrier?
Yeah, no, I think that's an absolutely important point. We know that food, as we've talked about, not only shifts the microbiome, but actually affects the immune system itself.
It does have those.
They do. They have maltodextrin.
How much do they have?
Exactly. And what is the interaction? And it may be a compound effect. We actually have another study that is being done currently by Dr. Lee, looking at the food additives that individuals eat and the likelihood of flaring in inflammatory bowel disease, because I do think that is a very important component of dietary therapy as well.
When we looked at the cost effectiveness of this diet, is this going to be a large financial burden for a lot of these families?
Yeah, no. So, I mean, I think that's a great point. So, the diet is a healthy diet, and I think Kim Brawley, who is actually, I think I officially give her a doctor title because she deserves it. Or she doesn't want it, she's saying. The diet is more expensive than the average American diet. There's no doubt about that. But if you looked at the cost of medications, that actually has a much more significant burden for many families, unless they don't have to pay for them. The number one cause of bankruptcy in the United States is actually medical care. And so I think it's important when we talk about, yes, it does cost more, and yes, it does take more time to do. We have to balance that out with, medications have their issues as well and are not necessarily cheap. Yes, sir.
Looks like biochemical markers improve in a 2 to 3 month period. When there's an insult to the diet, how quickly will you see them worsen?
Oh, that's a great question. We don't have a huge number of individuals that necessarily worsen, but I would say probably at around the 2-week mark, we know when somebody's going to be successful or somebody's not going to be successful.
I have a question. In the retrospective study, those 7 patients, did the parents, were they the ones that looked up the information on how to do the diet, or did they have diet instruction, or how?
Yeah, absolutely. So they were, at that time we did not have a program here at Children's, and those were all individuals who took it upon themselves. And I think that's one of the important aspects that we need to address with the SCD or with any dietary treatment. I think it's been done so often outside of the medical realm that the healthcare practitioners don't have a good handle on it. And then sometimes I think the patients don't necessarily get the follow-up and the care they need because they might feel like the practitioners are going to berate them, especially if they don't do well on the diet, and so I think that's one of the reasons that as a medical society, as a group, we really need to incorporate this into our programs because it provides a service and it makes sure that an individual gets the care that they want, and if it doesn't work for them, that we're able to shift it. Oh, sorry.
Just to confirm, these were all Crohn's patients.
For the retrospective, yes. For the prospective, it was Crohn's and ulcerative colitis.
And results were just as good with UC patients?
That's an interesting question. So we do see that patients with UC, some of them do well. I wouldn't say that they do as well as those with Crohn's. Again, this is based more on our clinical practice, and I have a slide coming up that will kind of talk about that. Sorry.
What percentage of the patients in your program that began on a specific carbohydrate diet eventually started immunomodulators and/or biologics, and what were the reasons for that?
That's a great question. I don't have a hard number to give you. I would say the long-term success is probably around 40 or 50%. I think that there are individuals who don't respond to the diet. There are individuals who do the diet and can maintain it for a while, but it becomes hard for them and they decide to switch off. So I would, say about 40–50%.
The difference between the way the formula works and the diet works. So would you say that perhaps the partial internal nutrition is not a good approach, or just not
This is my opinion, and it may not be shared by all. When we do EEN, we do EEN strictly, and so we don't do partial. We've had a number of individuals that we've done partial with, and we do see that it doesn't seem to work as effectively as full EEN. And it may be because you're shifting the microbiota, not in the best of ways, but when we do it to get them into remission, and then oftentimes we'll switch to SCD at that point.
What I meant was partial plus SCD. So what you're eating that is not formula is SCD. Does that work, or is that not?
No, we would do either formula and then transition to the SCD. We don't do the partial EEN with SCD.
So you had quoted saying that IBD was at much higher risk for people who had early exposure to antibiotics.
Yes.
Did they also look at kids that were born by C-section versus vaginal births?
There are a number of studies that have been done in that area, specifically coming from the Scandinavian countries. Interestingly enough, the two biggest studies, one study says, yes, there is an increased chance. The other says no. So you have to decide which way you want to go. I do think that probably impacts it as well, but I'm guessing that antibiotics have a big role too. Kronman, Kronman. O-N. M-A-N.
I was wondering if there's any evidence of the exclusive enteral nutrition or SCD also helping other types of like non-infectious colitis. I'm thinking like lymphocytic colitis or microbial.
It's a good question. To my knowledge, there's no studies in lymphocytic colitis or cholangiosis colitis or gastritis. I know that celiac or gluten-free diet for lymphocytic colitis has been reportedly successful in a number of cases, but that's the only dietary treatment that I know of that has been worked.
Have you been able to transition kids off biologics onto the SCD diet?
So I'm very much a pragmatist, and my whole desire is to make sure that the children that I take care of do well. If somebody's doing well on a biologic and wants to go onto the SCD, I don't necessarily encourage it, because the problem is none of us have that magic ball, and I don't, or that magic globe, and I don't want to ever get anybody flaring. Now, if they say, Dr. Suskind, I really respect you, but really no matter what you say, I'm going to go to the SCD, then I will support that. There's no doubt about that. But I wouldn't necessarily change somebody who's doing well if they're already doing well.
Because I have an 11-year-old who's been on the SCD diet for ileal Crohn's for about 4 months now, and it's not working.
Yeah.
They're really strict, and that was really strict. And so I put him on prednisone, and now he wants to do the prednisone, continue the SCD diet, taper off the prednisone, and see if the SCD diet works. Is that
Yeah, I think that makes perfect sense. And again, in the upcoming slide set, we'll talk a little more about that. But I think that some individuals need something else to get them into remission, and then SCD works to maintain it. So I think that's absolutely appropriate. But if it were something like Remicade and they'd been on it a long time, I would be hesitant to change.
Are you seeing the same improvements in extraintestinal manifestations?
We have yes, we have seen improvement, not as much in the joint issues, but we've had with with erythema nodosum, we've seen an individual do quite well.
You mentioned bacterial biofilm. What is your approach to that? What is your treatment?
With Crohn's disease, I mean, it's still the standard treatment. I mean, we don't necessarily see the biofilm in terms of when we take biopsies. You do special immunohistochemistry for that. But dietary approach or the standard steroids, it depends on the patient desire. No, I don't have any experience in that. Oh, yes.
For the children that you see in remission with symptoms on SCD, how often do you see the calprotectin above the norm, but maybe it's the norm for that child?
Oh, that's a great question. That's such a hard and great question. We don't actually have a great answer for that yet. There's a studies in colitis and Crohn's that looked at the number in relationship to inflammation in the bowels and clinical symptoms, and less than 150 was felt to be in remission, as opposed to the norm, which is usually less than 50. I use a number of less than 200 if they're clinically doing well. My goal is to get them less than 200, but we don't have a perfect number for people who have IBD. Last question, I apologize.
Yeah, is Cohen's study that was in JPGN in 2014 the only study looking at mucosal healing?
To date, that is, we've actually scoped a number of individuals who had been on the SCD, and we've seen at least 2 individuals who have had significant mucosal healing on the SCD. We had one individual who had fairly mild disease to begin with, but it didn't seem to heal the few ulcers that he had.
Is that going to be part of? Yeah.
Unfortunately, not part of our study, but part of Dr. Damon's study. Other questions? Oh, yes, last question, sorry.
So, inducing remission without a non-biologic and then transition to SCD, is it successful as just SCD?
I might suggest it might be even more successful, especially if you use EEN to induce remission. Steroids, maybe not, but if you used EEN to induce remission in Crohn's and then transition to the SCD, again, no hard data on this. This is just my gestalt, is that it's probably more successful.